Okay, so let's cover the last part of psychopharmacology. We're going to talk about substance abuse and addiction. We're going to talk about why some people get addicted and some people don't. So this is kind of stemming off of our talk about different kinds of substances and brain interactions and mechanisms for those different substances. So just to kind of making sure everybody understands the terminology, when we talk about substance abuse, we're talking about when a person uses a drug for those psychological and behavioral changes, um, you know, aside from whatever therapeutic effects that this particular drug has. They're essentially using it not for the prescribed purposes, but because of the psychological and behavioral changes. Um, and then addiction is or substance dependence is a more severe version of this, where we see frequent use of the drug. We tend to see a physical dependence as well, in addition to the abuse of the substance. We tend to see tolerance developing with a lot of different drugs. And then if the person tries to go without using the drugs, we'll see a lot of times very unpleasant side effects, which we refer to as withdrawal symptoms. If we look at substance related disorders, okay, looking at dependence or addiction, this is that a desire to self administer a particular drug of abuse, for example. And we see certain patterns of behavior. So we see the person, engaging in consumption. We see that the person's craving the drug. We see that they are invested time and energy, and that there's a significant impact on a person's life. And this might be a legal impact where they are caught with a substance that is illegal. It might be that they lose their job. It might be they don't go to school, or they lose relationships with their family. There's going to be some impact to their life, some negative impact. And this is more severe than just simple substance abuse, which is this pattern that doesn't necessarily meet the full criteria for dependence, that a person is sort of using a substance because of the psychological and physical effects aside from its therapeutic effects. And so if we look here at this table, so we have alcohol here and illicit drugs here, and you can see the proportions of North American men and women who are diagnosed at some point in their lives with abuse or dependence for, in this case, alcohol, and in this case, illicit drugs. And this is according to the DSM-5 criteria. So you can see the distinction between abuse of alcohol and then dependence, and you can see the likelihood of the diagnosis, and then here again, abuse versus dependence in men, women, and then total. So you can see that men tend to both abuse and be dependent on alcohol compared to women. Same thing with illicit drugs. So there are a few models of drug abuse that we can kind of identify. And so one is the moral model. This is where you take the blame and you put it on the abuser, and you say, you know what, you don't have any self-control, you lack moral character. This is a really dangerous model because there's a lot of evidence that substance abuse and addiction and dependence, there's some genetic components to that. So by saying, oh, it's almost like victim blaming, placing back on the abuser and saying it's because you chose this path. That can be a very, very dangerous model. The disease model says that the abuser requires medical treatment, that it is an actual disease. But some issues with this is that an abnormal condition in abusers hasn't really been identified. Now, once drug use has impacted the brain, of course, we see different things happening as a result of drug use. But before that drug use, there's really not a lot of evidence that there's any sort of abnormality there. We also have the physical dependence model, and it's also referred to as the withdrawal avoidance model, and says that the reason why an abuser uses a drug is because they want to avoid feeling the side effects of no longer using the drug, those withdrawal effects. And this works through negative reinforcement. So if you guys remember, negative means the removal, right? The removal of something, a lot of times something unpleasant. Reinforcement means that you're going to see an increase in behavior. And so an example of negative reinforcement is when you get into a car and you hear this incessant beeping, you put your seatbelt on. So it increases the likelihood that you're going to engage in safe driving by putting your seatbelt on, because you are getting rid of this unpleasant beeping noise. So the physical dependence model basically says that if a person is using a particular drug, they're going to keep using that drug so that they don't experience a withdrawal effects of not using the drug. And so if you scale back, you're going to not feel well, and you're not going to feel the effects of the drug, and therefore you're trying to avoid that. And so it's negatively reinforcing, meaning that you're going to continue to take the drug because you're avoiding the unpleasant effects of withdrawal. The positive reward model is basically that that the drug use is a behavior that's controlled by positive rewards, right? So you're just taking it because you enjoy the effects. So there's it's positively reinforcing. And so we have two sort of types of dependence. So we have this physical dependence and then addiction. Addiction is much more complex, involves a psychological component. Physical dependence would be indicated by the person experiencing tolerance for the drug, meaning that they have to continue taking more of the drug to feel the same effect that they originally felt the first time they took it. Withdrawal would indicate that they have a physical dependence, because as they remove their dosage of the drug, they're starting to feel the effects of not having that drug again and experiencing the side effects. Addiction is much more complex. It's the neurobiological, psychological, social, environmental factors that all play in to why they are using the particular substance. Now, if we look specifically at withdrawal, so withdrawal symptoms, this is what we see happening when a person scales back their use of the drug or stops it cold turkey. Depending on the drug, we can see some really serious physical effects. And in some cases, it's actually more dangerous for the person to quit the drug cold turkey because it could potentially kill them. So what is typically recommended is that a person goes through withdrawal in maybe a facility or a place that they can be monitored to make sure that physically they are able to get through it. But we might see things like muscle aches and cramps, anxiety attacks, sweating, nausea, convulsions. It just depends on the kind of drug. Typically, we see with withdrawal symptoms, it might have the opposite effect that the drug had. So, for example, if you're taking an opioid, one effect of opioid is sort of slowing down the digestive system. You tend to be constipated. And then when you go through withdrawal from opioid addiction or use, we might see that the person has very upset stomach, really terrible diarrhea, because it's the sort of opposite effect. We also might see that they're much more sensitive to pain, because opioids help to control pain management and to help a person not experience as much pain. So we might see the person be more sensitive to pain. And so there's a different time course for every drug in terms of when those withdrawal symptoms kind of kick in. If we think about like caffeine, right? So you have an addiction to caffeine, and you consume caffeine every single day, and you go one day without it, you might see those withdrawal effects happen within a few hours of you not getting your next dose of caffeine. So if you normally get a cup of coffee every single morning, and then that morning starts hitting around lunchtime and you haven't gotten your cup of coffee, you might start experiencing a headache or feeling really slowed down because you're experiencing those withdrawal effects. Now, alcohol and morphine, those withdrawal effects start within several hours of the last dose, and they're going to intensify over several days before going away. And again, this time course is different for different drugs in terms of how fast they start and then how long they last. You can also see psychomotor activation. So you're going to potentially see some increased behavioral and cognitive activity depending on the drug type. We've talked about the different kinds of drugs, but a lot of times we see activation even if that drug is more inhibitory. So we might see some behavioral, cognitive activity. The drug user may feel very energetic, might feel in control when they've gotten their dose. And we see this a lot of times in these addictive drugs. And so the question is that because there's some kind of common target that we see in those drugs that are tend to be more commonly abused. So what is the pattern? This pattern here, what is the common link between these commonly abused and addictive type substances? How does it work in the brain? Well, many addictive drugs cause a dopamine release in the nucleus accumbens. And so this kind of track here, the ventral tegmental area, amygdala, nucleus accumbens, this pathway is really important for the reward pathway. So we know that in the nucleus accumbens right here, this area here, we see that being the prime area for the reward pathway and for seeing dopamine release. Some axons that terminate here originate in the VTA or ventral tegmental area, so they kind of end there. This is again involved in the reward pathway. So anytime you feel anything that's rewarding, you see your favorite person, you eat your favorite food, you enjoy your favorite song, this could potentially, this pathway essentially is activated, and dopamine is moved along this pathway. And so the idea is that these addictive drugs initiate this pathway and hijack it. Now, it's not just drugs that do this. Sex, shopping, exercise, games, gambling, any kind of addictive behavior has the potential to activate this rewarding system, which is the reason why we call these things almost like an addictive drug, right? So you can be addicted to sort of any behavior if it's going to activate this reward pathway. So it's not just addictive drugs. Another interesting pathway involves the insula that we think that might have something to do with addiction, and this is located within the frontal cortex. What we know about this is the power of deduction. So in a person who, there have been several case studies of this, so a person who is a smoker, has been a smoker for many years, might have damage to the insula and then literally wake up and not want another cigarette. And they're just done. They don't need to smoke anymore. And so the idea is that if the insula is damaged and this person who was addicted to this substance for many years wakes up one day and suddenly says, I don't need this anymore, perhaps this has something to do with addiction. And so the idea is that there may be these reciprocal connections between the VTA and the insula that basically mediate addiction. And if you mess up this connection, okay, for example, damage the insula, then you're going to potentially impact the likelihood that person is going to continue with their addiction. When it comes to pleasure and dependence, right? What we find is that the initial experience, the first time or two they use this drug, they might experience great pleasure and great euphoria. And so then they continue to then look for this same high. They often call it like chasing the dragon, right? And the problem is when they see this drug effect wear off, that's when they start experiencing physiological as well as psychological withdrawal symptoms. And that is going to encourage them to continue using the substance. Now, if you look at this process acutely, you say, okay, this makes sense. You know, you're using the drug, your dose wears off, and now you're like, oh, man, you know, I don't feel well. I want to take another one to keep this feeling going. Well, in some cases, an addict might actually abstain from a drug for a very long time, months or even years, long after those withdrawal symptoms have gone away, but they're still potentially going to be drawn back and using it. So what is our explanation for why is it that a person might continue, basically not using a drug for months or years, but then come back to using this drug? So we're going to talk about cues, and we're going to talk about how a person might see a particular drug cue, and that might change kind of how they want the drug. But one really interesting model is this idea of wanting and liking. Okay, so wanting a drug and then liking a drug tend to go in different directions with repeated drug use. So at first you want the drug and you like the drug very, very, initially. But then after that point, you end up wanting it, but you don't like that you want it, and you don't like the drug, you just kind of need it. And that's where we get craving, right? And we tend to see this associated with drug cues. So when a user receives a cue associated with taking a drug, so for example, if they take a drug intravenously and they see an IV, or they see a syringe, if they see paraphernalia associated with that drug, that activates the mesolimbic system at releasing dopamine. So just seeing the drug cue, just seeing the drug taking cue is going to already start activating this system. And this dopamine release is the neural correlate of wanting. So that's the explanation behind wanting. There was some studies done looking at posters that were placed around for different, basically saying, you can get help with this particular drug use. And it was a bunch of syringes that were kind of in a circle on a poster. And it was found that in of itself, just demonstrating and showing these drug cues was actually resulting in the likelihood that that a person was going to relapse because of this process, that mesolimbic system becoming activated, releasing dopamine in response to just seeing something related to their drug use. We also see this happen when a person is going back to the place that they used the drug. So when a person goes to rehabilitation, a lot of times they're encouraged, don't go back to those same people. Don't go back to those places where you use drugs, because they are serving as cues. They're going to be reminders, and those reminders in of themselves are rewarding. So that's why it's really important during the process of like when you're withdrawing and when you're rehabilitating, to not engage in the same relationships and not engage in the same places. So looking at dependence in general, the decision to take a drug is made in the frontal cortex. Your frontal cortex is what's telling you, let me do this thing, right? This is your decision-making center. The drug is going to activate opioid systems, which are related to feeling pleasure. Wanting a drug is going to spring from activity in the dopaminergic system, very similar to actually taking the drug. And that voluntary control of the drug taking, is going to then give way to an unconscious process, which we refer to as a habit, which is involved in this striatum. So it's really difficult to say for sure that you're in control when you have all these other neurological things happening as a direct result of seeing cues, of thinking about the drug, of previous use. Now, other things like cues related to sexual activity, food, sports, that's going to induce that wanting, right? And sometimes we'd see it in the absence of liking. Remember, we talked about this relationship here, that these are in opposite directions. And think about your own behavior. Have you ever eaten when you're not hungry? Have you looked at other people eating and go, well, I could eat, right? But not being hungry and not even really getting a lot of pleasure out of actually eating, but you're doing it because you're like, well, I want it, I don't like it, but I'm just going to do it. So we tend to do this quite a bit without even realizing this is the same behavior that we see in a person who is engaging in drug abuse. Now, the interesting thing is that addictive drugs can actually influence gene regulation. Now, it doesn't necessarily, we're not talking about influence DNA. We're talking about turning on and off gene expression. So the genes that are important for voluntary control, right? Those behaviors that make you more susceptible to addiction can be turned on and off, expressed, not expressed, due to drug use. Okay. Now, some of these changes are actually permanent enough that they can be passed along to the next generation. So there's been a lot of evidence to suggest that fathers, not mothers, but fathers who engage in abusive alcohol, like dependence, right? Abused alcohol and became a dependent on alcohol, have increased the susceptibility of their children also engaging in alcohol dependence and being dependent on alcohol, because these permanent changes, these gene expressions turned on, made that next generation more susceptible. So you can have a person who has a family history of drug abuse or alcohol abuse and then be adopted into a completely different family with a wonderful environment, you can still see that person become susceptible to drug or alcohol addiction because of the genetic component. And then we refer to this, of course, as epigenetics, right? That's above genetics. And that is something that we still are trying to get a good handle on. Now, another thing that we can talk about is how do we treat this, right? How do we treat people who have engaged in drug abuse? How do we help these individuals? Well, we can do things like lessen the discomfort of the withdrawal by prescribing things like benzodiazepines, something that's going to suppress that central adrenergic activity and help ease the cravings and help ease those withdrawal symptoms. Especially acutely, this might be helpful in getting the person over that sort of withdrawal hump, right? You can provide alternatives to addictive drugs. So you can have an agonist or partial agonist that doesn't work as well as the drug, but it's going to partially activate those same pathways. One example that most people are familiar with is nicotine patches. So if you're trying to quit smoking, you might sort of wean yourself off nicotine by using a patch. It's not as good as smoking, right? But that's the point, is you're kind of weaning yourself off. Methadone is also used for opioid addiction to get the person off of the drug. Suboxone, same sort of thing. You're trying to wean the person off to get them something that is an alternative to the addictive drug that's not as damaging, is not as harmful. You can also directly block the actions of the addictive drug. So for example, if you have a particular person with a addiction to alcohol, you can give them a medication that's going to block the effects of the abused drug. But usually, if the person's going to engage in drug use, it's going to really, really make them sick. And also, it's going to that drug itself might have some withdrawal symptoms. May produce withdrawal symptoms. You can also alter the metabolism of the abused drug. In essence, you can give somebody to change the breakdown of the drug, so it can change, reduce, reverse, the rewarding properties. Anti-abuse is an example of this. If the person consumes alcohol while taking anti-abuse, it essentially wipes out the enzyme to break alcohol down, meaning that's going to make the person really ill. They're going to feel really, really terrible, and it's going to be something that they are not going to be happy to have. If you have a person, for example, who is experiencing an overdose, an opioid overdose, for example, you can give them a Narcan or naloxone, and that's directly blocking the actions of the drug and can reverse the effects of an opioid addiction if you get to them fast enough, because it blocks the opioid receptors. Okay, so last couple things. So we have, of course, medications that we use to treat drug abuse that can block the brain's reward system, but it might block the pleasurable feelings completely, and the person might feel like a lack of pleasure of anything. Because remember, if you're dampening this pathway, then you are really, for the drug abuse of choice, you're also potentially dampening it for anything that is pleasurable, as in, seeing the person that you like, enjoying a stroll in the park, anything that's pleasurable. There's also been some really interesting recent work on vaccinations that might be effective for prompting the immune system to reject and remove targeted drugs. This is an example here where we have a vaccination strategy for cocaine. So it can be this anti-cocaine vaccination can be effective in various models. And so if we look at these control animals, let's see here, if you look at the lab animals that receive cocaine, they tend to show really agitated behavior, and they are, running around and they're moving a lot. They have very high behavioral stimulated behavior. And then animals that are previously treated with the anti-cocaine vaccine, they don't show the behavioral effect of cocaine, the behavioral evidence of cocaine. So what that's basically showing is that they're almost immune. They're becoming immune to the effects of cocaine. So some really interesting directions there. So the last kind of thing I want to talk about, last couple things about drug abuse, is looking at why don't we engage in drug abuse? Why don't some people engage in drug abuse? So you have a person who has had a surgery and they're prescribed an opioid and they take it for 2 weeks and then they're done. Like, they don't become addicted and they live their life. And this happens to a very large portion of people. They might take they might take cocaine for the first time ever and then never become addicted to it. They might take any kind of a substance and then just not become addicted to it. So take a second and pause. I just want you to kind of read through these comics. So there's experiment 1 here and then experiment 2 here. So I'm going to give you a second just to pause, and then I'm going to kind of explain what happened here. So in experiment 1, what they had is they had a specific experiment where they had a very enriching environment for these rats. And so one thing that we typically see in animal studies of addiction is that rats are extremely isolated. They're in an unstimulating environment. They're just in a cage, right? And they will act like addicts when they're in an unstimulated environment like that. Like, if you put them in a cage and you give them access to drugs, they're gonna go into a drug-induced stupor, and they're gonna behave like an addict. When you have a situation where you have a really stimulating, fun environment, and you provide drugs to rats in this situation, you will actually see that the rat avoids taking the drugs. They avoid the effects. They really don't. They're not going to engage in drug use. Okay, and so the idea is that context is really important. If you provide a very stimulating environment where the person doesn't need to engage in drug use and they have other things to do, a life to live, things that you're, continuing on, the idea is that you tend to not become addicted because you're finding pleasure in other things, right? And so in this case here, these are happy little rats that are just doing their thing, and they're in a nice environment, they're living their life, they don't need the drugs. Whereas here, there's a very unstimulating environment here where the cage rats, they're just kind of taking the drugs and they're just in a stupor, and there's nothing else exciting for them to do. So if we translate this to humans, if you are taking medication that's abusive, that's potentially can become addictive, take the drug as prescribed and then continue living your life. Like, go on and do your thing, and don't take more than you need. Don't engage in, pondering the drug. Become, invested in your life and continue on. If you are using a drug and go through rehabilitation, it's found that putting yourself in a stimulating environment away from those cues is also really helpful. And that's how we have come across experiment 2. And so in experiment 2, the experimenters made all of the rats physically dependent on the drug. In this case, they were given sort of choice days where they were given water, they were given morphine solution. And the caged rats increased morphine intake on those choice days. And then the park rats, which are the ones that are in the stimulating environment, they decreased their drug use on choice days. They actually were okay with those, withdrawal symptoms to return to their normal life. So when you put it in terms of context and having a stimulating environment and a life and something that a person is looking forward to, the idea is that this could have an impact on if the person becomes addicted to begin with. And if they are addicted to a substance, it can impact whether or not they can recover from this. And there have been a lot of really great programs that are not in the US that are actually in other countries, where they take people who have been addicted to substances, instead of throwing them in jail, they actually put them as part of a community. And there's, give them a purpose and job, and have them live, very stimulating lives. And they've had really great success with those programs. So most people who use drugs, even recreationally, they don't become addicted, right? So why is it that we have people who become addicted other than, looking at the context, right? So of course there's biological factors. We looked at the, men versus women and susceptibility to addiction. We also can look at genetics. There's personality characteristics involved in so susceptibility for risk-taking behavior, aggressiveness, emotional control, and inhibition. We can also look at family situations, right? So we can look if a person is in a good relationship, if their siblings are drug users, if they are in a situation where they've had trauma as a child. These are all things that can impact the susceptibility of a person to addiction, as well as other social and environmental factors, right? So looking at social isolation, looking at peer pressure. These are other things that a person can be at more risk for if they feel the pressure to use the drug and they don't feel an out. They haven't been sort of trained or inoculated on how to address those societal pressures or even peer pressure on engaging in drug use. And social isolation is also really important because this is part of this whole like rat part experiment, right? If you're in a very unstimulating environment without a lot of social stimulation, that could be a problem for the person, and make them more likely to engage in drug use to kind of escape that situation psychologically and emotionally. So if you have any questions, you know how to reach me. Hopefully this kind of furthered your knowledge on drug use and addiction.